Onc Live Insights is a video editorial program produced by Onc Live.
The majority of gastrointestinal stromal tumors are sporadic tumors. However, there are some that can be familial. Specifically, we know that there are families that have inherited mutations in c-KIT and also overexpression of c-KIT that can lead to gastrointestinal stromal tumors. There are also children who can have GIST, although this is very uncommon. In those, there are specific mutations that lead the children to develop GIST.
So what determines prognosis in GIST is actually where the tumor arises from, how big the tumor is, and what the mitotic rate is of the tumor, which is probably the most significant factor. So those three factors actually risk stratify patients who present with tumors. And there are several nomograms that are available that you can plug those factors into and figure out exactly the percent of percentage of risk of recurrence in these patients. Part of evaluating these tumors should be evaluating the mutations that these tumors have, as it's prognostic, and potentially even now there's data to suggest that these mutations are predictive of response to various therapies. The most common mutations are actually mutations of KIT, and exon 11 and exon 9 are the two most common mutations, exon 11 being most common. And those patients tend to be more responsive to imatinib. Exon 9 mutations tend to be a bit more aggressive, may be more responsive to higher doses of imatinib or Sutent. And then other mutations to evaluate would be PDGF receptor mutations, which are probably the second most common mutations that these patients present with.
Importantly, what we're looking for is to determine if the tumor is confined to one area, or if there is multifocal disease or metastasis. Importantly, GI stromal tumors only rarely occur in the lungs or in the lymph nodes, so the most common sites of disease would involve the stomach, the small intestine, and to a lesser degree other areas of the gastrointestinal tract. There are very rare occasions where these tumors may occur outside of the GI tract, usually in the mesentery or sometime around the prostate gland, which can be tricky. Now, once the diagnosis of GIST is made, I think the best way to manage these diseases is for them to be evaluated in a multidisciplinary setting, preferably in a high-volume center that deals with gastrointestinal stromal tumors. This may be in the context of a sarcoma group, or it may be in the context of a group of specialists that deal with gastrointestinal cancers.
The location of GIST is important, specifically after surgical resection, because we know that the risk of recurrence is dependent on several factors, including location. Patients with small bowel GIST have a higher risk of recurrence compared to patients with a gastric GIST. The size is also important. Tumors that are larger than 5 centimeters in size have a substantial higher risk of recurrence compared to tumors that are smaller in size. Also, tumors that are 10 centimeters in size have actually a very high risk of recurrence. Other features that are important in GIST is the mitotic count. So we look at this and define this as 5 per 50 high-power fields, which is usually for most microscopes 5 per 5 millimeters squared. In patients that have these high-risk features, it includes in patients that have high-risk features, which includes tumors larger than 10 centimeters, or if the tumor is larger than 5 centimeters but has a high mitotic count, we define these tumors as being high-risk tumors. These are often patients that after surgical resection will benefit from additional adjuvant therapy to decrease the risk of having a recurrence of their tumor.